Unlike Marianne, I can't talk for half an hour without slides, and so I provided myself with, I don't know, 30 or 40 of these slides to describe some research that we conducted in Scotland into the problems in communication in primary care. So first of all, I need to acknowledge my co-workers. Most of this research was conducted by a couple of young researchers over a period of about 5 years. They're Katie Gordon and Rennie Blomqvist, and there was an extensive advisory board of which I was a member, and hence why I'm presenting today. What I'm going to cover is I'm going to tell you about the charity, because this work was conducted by the charity Pain Concern, and give you some background to the projects, including a definition to self-management. I'll talk about the two projects that kind of formed the basis of this work, the Barriers Project and then the Navigator Tool project. And I'll go into detail with the Navigator Tool project, tell you about what it's structured like and how to use it, and the work we did on evaluating its impact in consultations in primary care. And then we'll finish off with some conclusions and discussions about the future of it. So Pain Concern is a charity that was founded in 1995 by our current Chief Executive, Heather Wallace. She founded the charity after completing the pain management program at the Aston in Edinburgh. And she was so taken with this self-management approach that she went on a mission to make sure that others could hear more about it. And as many of us know, the pain management programs are probably only taken up by, offered to a minority of people with chronic pain. So she was determined to get these messages out to a much wider audience. So since 1995, the charity's been aiming to educate people who are living with persistent pain in their self-management efforts, and their work consists of a helpline. There are various leaflets which are all downloadable from their website on the major topics in self-management. They also produce a quarterly magazine, and one of the more interesting aspects of what they offer is they have a series, I think, of about 150 hour-long podcasts, which they call Airing Pain, which cover a variety of topics, every topic that you could possibly think of. And I would encourage you to go and have a listen to some of those. So all of this work was conducted in Scotland, and I'm speaking to you today from Glasgow. So talk about the Scottish context. Of course, when people think about Scotland, they tend to think of the beautiful Highlands. It is, of course, God's own country, with probably Canada coming in a close second. It's not just beautiful mountains, though, and remote scenery. It's a post-industrial society, and it has a kind of central belt of Scotland that has a lot of social problems. So important to mention those. Scotland's got a population of nearly 5.5 million. It has a public healthcare system similar to the rest of the UK, the National Health Service. And there are some differences in Scotland, though, because the healthcare system is a devolved power, so it's managed by the Scottish Parliament. And in Scotland, it's much more centralised than it is in England. There are 14 health boards, the largest being the one I used to work for, Greater Glasgow and Clyde Health Board, which has a population of 1.1 million, right down to the small island ones that can have populations that are very small. Excuse me, just taking a drink. And when I say they're centralised, probably different from the North American context in that the pain services in each of these health boards are unitary, so that everybody who works in managing chronic pain in the kind of specialist settings all works for one organisation. So Glasgow, for example, has a pain service that is spread over 4 or 5 sites, but everybody works under the same management structure. And there's some advantage to this kind of centralisation in Scotland, in that it's probably easier for the government to make changes and to get messages across. The Scottish context as well also includes a kind of long-standing political interest in chronic pain. It's hard to say why this is the case, but I suspect that it's down to a kind of few individuals who've annoyed the politicians over the years about ensuring that people with chronic pain get the best possible treatment available. And the Scottish Parliament has a cross-party working group that has been running for many years. There's been various publications and so on. And the other aspect about the Scottish context, I think I was reading somewhere else recently to do with the conference about somebody suggesting that chronic pain should be recognised as a disease in its own right. And this is something that the Scottish government did a number of years ago. The other thing, though, is that they have an enlightened belief in patient choice, as well as ongoing concern about over-medicalising and over-treating conditions. And they produced a series of reports under the heading of Realistic Medicine, which are fascinating documents. And again, it's something else I would urge anyone who's interested in the organisation of healthcare to go and have a look at. They emphasise self-management as part of the management of all long-term conditions, and in fact the management of all conditions more generally. So that's the Scottish context. Around about the time that we received funding to do this project, there were a kind of raft of other reports being released from the Scottish government. I'll translate the one on the left-hand side of my screen, the purple one, Go On Yourself, which is Go On Yourself. And it's the Scottish government's strategy for encouraging self-management in long-term conditions. And I think that was published, I'm thinking probably about 13, 14 years ago. As I said, there's been various reports on chronic pain services in Scotland. The most recent one, I think, was in 2009. And the Scottish government has also commissioned a group of clinicians and researchers to produce guidance on the management of chronic pain in primary care. That's the SIGN Guideline 136, which I was one of the authors of. So there's a lot of things going on in the background around self-management of chronic pain. And then, so a brief definition, of course, a single approach or combination of approaches that can be initially taught by any health professional or learned by an individual to enable them to minimize the impact their chronic pain has on everyday life. But I'm assuming that I'm teaching my granny to suck eggs here. You'll all be aware of the definition of self-management. So as I was saying, there was this policy background, and then a number of things came to head at the same time. The charities helpline was constantly receiving calls from people suffering from pain that they were having difficult consultations in primary care. So frequent complaints that their GPs, the physiotherapists, the pharmacists and so on weren't listening to them, and often reports of conflict in those consultations as well. The other part of the background, and this is kind of a bit of a motive and a difficult term, but patients with chronic pain are often referred to or seen as heart sink patients, the kind of patients that make your heart sink when they come into the consultation room. Obviously, those of us working in chronic pain don't feel like that, but it reflects that recognition that they're seen as difficult people to help. And we have had the ongoing background of the opioid crisis causing further problems in those consultations as well. And I'm sure many of you will have encountered this as well, with the evidence directing us away from prescribing opioids, and yet many patients regarding these as the only thing that is helpful to them. So there's lots of things going on. And then the Scottish Government, through the Health and Social Care Alliance Scotland, in combination with the Edinburgh and Lothians Health Foundation, offered grants to improve the self-management of chronic pain in primary care. And the charity saw this as an opportunity to try and improve all the problems that it kept hearing about on its helpline. And so we applied for some money, principally and initially just to investigate what was going on that was going so badly wrong in these consultations. And we employed a researcher who then set about investigating this by gathering focus groups of people living with persistent pain, as well as healthcare professionals across Scotland, and asked them about the problems and the difficulties that they'd encountered in these consultations. And if you can see from this slide, we had, I think, 54 people with chronic pain as participants, and 9 of their carers attended these focus groups, and nearly 40 healthcare professionals. And these focus groups were conducted across Scotland, mainly in the Central Belt, but a couple of the more remote areas like Dumfries and Galloway in the Highlands of Scotland. Those focus groups were recorded, transcriptions were made of them, and then those transcriptions were subjected to thematic analysis. And 4 kind of themes emerged from that thematic analysis, and those themes were focused around the consultation itself, patient's experience, the limited treatment options that are available, as well as the organizational constraints. And I'll go through and illustrate what those themes look like. So this is a patient who is saying, you end up picking up this bit or this bit or this bit or this bit, and then trying to join them together. And that works. That might be over 10 years as opposed to over a couple of months. So that kind of difficulty of piecemeal provision of self-management information being hard to pick up. And a GP saying one of the difficulties that they encountered, and this was a kind of frequent report, is as soon as you go down that route of discussing emotions, they found that the patients would accuse them of saying that it's all in their head and they're making it up. And that's a difficult road for them to try and navigate and to manage. And in terms of the patient experience, I think self-management can be a slightly off-putting term for some patients, signaling that the doctor's not interested, saying, on you go, I can't do anything about this, you have to deal with this yourself. And patients saying, I think one of the hard things that is, as well as you don't have a diagnosis, you go from A to B and it's not this, so we'll try this, and you understand that it's about elimination, but it can be very frustrating. Limited treatment options also interrupted the provision of self-management advice in primary care consultations. And GPs were often found saying, at medical school, they were trained that if there's a problem, there's a solution, and those solutions most times are to do with giving patients prescriptions. And of course, patients have those beliefs as well. When you go to the doctor, you expect to walk out with a prescription for some medication. But physios were saying as well, they're aware that they should be doing self-management with their patients, but when you've not got any training in it, it's like, what do I do? Where do I start? It's a massive area. So having that resource and having a refresher is obviously really good. And there's organizational constraints as well, and the kind of well-documented, time-limited GP consultations, usually a maximum of 10 minutes, and that leaves GPs feeling like they've got little time to do anything else apart from just give a prescription. And the patients themselves noticing this as well, feeling that they weren't being treated holistically. If they required any specialist help, they were being sent off to separate services, so feeling like they were hacked off into bits and separated out into separate parts of the NHS. So we managed to write this up, and we published this research in the British Journal of General Practice. It's their barriers to self-management with chronic pain in primary care. And the results of that compare very similarly to other qualitative studies that have been done looking at barriers to self-management, not necessarily with pain, but with other chronic conditions as well. And kind of similar stories were being told in all of these studies. So the Barriers Project found that healthcare professionals and patients both found it hard to discuss self-management. Emotional problems were particularly difficult for both sides to cover. And that the medicalization of treatment often prevents progress with adopting self-management strategies. And that self-management advice itself needs time and also a structure to kind of help both sides make progress. So luckily the Scottish Government offered more funding, and we again took advantage of this and employed our second researcher to develop tools that people can use in their consultations to improve self-management. And we came up with something called the Navigator Tool. And what is it? It's a ring-bound document. I have a copy of it here as well. It's also as a downloadable, the first part of it is a downloadable interactive PDF from the Pain Concern website. And the first part, it consists of the My Pain Concerns form, as well as questions to ask your health professional. I'll go into these in a second. And the second part was describe self-management strategies and goal setting that might be helpful for people to adopt self-management approaches. And training was initially given to healthcare professionals in how to use it, but certainly the first part I think you can use off your own bat without any training. So what the tool aims to do is to ensure that each consultation is focused on the concerns which the people in pain wish to discuss. So it's very person-centered. It aims to empower people with pain to be a partner in their consultation and not just a passive recipient. And it also aims to facilitate self-management discussions early on in the pain journey and encourage adoption by both parties of the biopsychosocial model of healthcare. And the healthcare professionals are clearly asking for this: train healthcare professionals in skills to support self-management so that it makes the best use of their time during consultations. So this is what the Pain Concerns form looks like. It has 4 sections, an area where people can raise concerns about diagnosis and cure. So they can, if they can tick that they don't know the cause of their condition or don't understand their diagnosis. There's a section on emotions as well, the way that I'm feeling low, stressed, lonely and isolated. Changes to life and to function is also covered as well, so people can raise concerns about feeling isolated, not being able to work, not being able to carry out their normal activities, not being able to sleep and so on. And also a section devoted to concerns about medication, and we know that people always have lots of concerns about these. And these are followed up with specific wording of questions to ask your healthcare professional if you were to endorse a specific concern. And the reason for this is you know yourselves that in consultations, if questions are asked in a certain way, they can get a favourable response from the healthcare professional. And so these were phrased in order to elicit the most helpful response from the healthcare professional. So if somebody thinks that not enough has been done to find out what's wrong, they can ask, is there anything more that could be done to find out what's wrong? Have all reasonable tests been carried out, and so on. And that goes over into it's covering emotions and medication as well. So the second part consists of a self-management options grid that covers in very brief form what the strategies of pacing, spacing, reviewing medication, taking part in activities, relaxation, movement activity, and managing worries. And there's also a part that the healthcare professional and the patient can fill in together that covers goal setting and how to break those goals down into specific actions that can be followed up over a period of time. So you can see that some of this, the kind of full Navigator tool would probably involve some training, but certainly the first part is most helpful if it's given out to patients prior to the consultation so that they can bring their concerns into the consultation and then they can be addressed. And we've now put it up on our website as well. There's the concerns form and questions to ask your healthcare professional so that patients can download it and take it along to their consultations. So we conducted a pilot study, a very small one, with a couple of GPs, a couple of pharmacists and physiotherapists, and we recruited 35 patients from primary care that all have had pain for longer than 3 months. And again, we gathered some quantitative measures, but they're kind of too small numbers for quantitative feedback to be very meaningful. But we got 15 patients to rate the tool. And what we found that not everybody used all sections of the tool, or that they used it flexibly, and that depended on the patient profile. But all the healthcare professionals and 8 of the patients were interviewed as well, so we got some qualitative feedback as well. So most of them, nearly all of them, said the tool was easy to use and that it improved their communication with their healthcare professional. Most of them used the My Concerns form, and the goal setting form was found to be particularly helpful as well. The other aspects were maybe less used. The self-management options grid was used the least. And in terms of qualitative feedback, some patients were saying it got them thinking more of the positives than just on the negatives all the time. Helped them to see that they had been able to make progress. And it kind of validated concerns as well. So rather than worrying that they were wasting their GP's time, it allowed them to talk about other issues related to pain. And the healthcare professionals also had positive feedback as well, that they said that it opened up areas that might not naturally come up in a routine consultation. And that patients were taking ownership of the tool. So one of them, the pharmacist, said that even though they'd been to a motivational interviewing course before, that was all about how you, as the healthcare professional, lead the conversation with the Navigator tool. They felt that the patients were leading them. Again, another GP from a medical perspective mentioned that it's often difficult to get patients to understand that there is often a psychological element to pain, and that simple concepts like that are hard to get across without offending people and putting people's backs up. But because the tool was there, it quite effectively did that on its own by kind of giving permission to raise those topics. And this is very pertinent in light of Marianne's talk here, that using the tool had enabled one lady to speak to her boss, another to speak to their link worker to get help with benefits and money, other to go on to a community pain service, which is group work, and they felt that they wouldn't have been able to do that without the Navigator tool. I'm just going to play you a very short 1 minute long video, just some clips of patients and healthcare professionals talking, but on the Pain Concern website there are, I think, 3 or 4 much longer videos, about 20 minutes, half an hour long, that give you much more of a flavour of the tool, but here's just a snippet.
It's a revelation to use something like this in the consultation.
It changed the way they think about their pain. It was an educational tool. It very commonly brought out problems in their lives or their history or their experience of chronic pain in the past that they hadn't really ever considered might be relevant.
It focused me on actually what I was coming to the appointment for. I was homing in more on what was bothering me about that. Was it that I was unsure about the diagnosis? Was I worried that I was on the wrong medication?
What the toolkit and using that helped me to do was to look much more effectively at the patient's life, how it was affecting them and how I could specifically support them to make changes.
So that was the video. So reflecting on how the tool actually manages to produce these improvements, I think there's no doubt about it that it puts patients in the driving seat. So they're the one that are bringing their own specific concerns. It hears and validates the experiences of people living with pain. So, but simply by listing all of those problems in a document that is given to somebody with chronic pain, it can help them to kind of normalize the experiences that they've been having of the various difficulties that they've encountered in their lives since they've had pain. And I think this is a key aspect. It gives permission to raise other areas of concerns for both patients and healthcare professionals. And that's been particularly important around concerns about emotional well-being. And it allows for other solutions to problems apart from just pain relief, and demedicalizes the consultation, so it's not simply focused on investigations and treatment for pain. And I think this sums it up really nicely. It moves away from patients coming into the consultation, and normally, in my experience, how they go is that they come in asking for something to be done about their pain because they see that all of the problems that they're experiencing are arising from their pain. And so therefore, if you just treat my pain, all those problems will go away. And as all of us working in this area know, we wish it was that simple. Treatment of chronic pain is extremely difficult. And so it moves the conversation on towards help me to live a better life. And those can be much more productive conversations. And of course, it's a nice, glossy, professionally constructed thing as well, which I'm sure always helps. I'll just briefly tell you about some other uses. As I said, the secondary care specialist pain services in each of the health boards in Scotland, normally, well, a number of them now are working on the process of not just simply inviting patients to their first consultation with a medical doctor, and usually that's a consultant anaesthetist with an interest in pain management. Instead, a number of health boards have adopted this model where they are starting out with an information session to kind of brief patients about what the service has to offer. And those following on from those briefing sessions, there's a follow-up chat, and patients are, at the end of the information session, are given the pain concerns form and questions to ask your healthcare professional, and they bring them back for a discussion with one of the team, and they so they're used currently in Glasgow, Aberdeen, and Inverness. This enables patients to say that service is not just medical, but it quickly identifies problems with mood and function, so that instead of everybody going to see a medical professional at first contact, they can be directed alternatively to a more appropriate team member, one of the psychologists, OTs, or physiotherapists. And it gives the pain concern form gives the concerns form gives a clear and acceptable rationale for seeing those other team members, which can, I know from my medical colleagues, can sometimes be a difficult sell. So just finishing off, the tool itself has had encouraging feedback. It seems to improve relationship consultation quality, helps to quickly move treatment onto a self-management agenda, and it's finding use in triage in secondary care pain services to move patients onto the wider pain team more quickly than normally would happen. Further evaluation is needed. These are just very small studies that we've conducted. I can envisage, I've got a design in my mind for how a randomized controlled trial might work to demonstrate its utility. And the charity is keen to find partners for future development. So that's all I've got to say. And I think I've got some, invite you to ask questions now. So I'll stop sharing. Stop sharing. There we go.
That was fascinating. Thank you, Martin. I do have a few questions. It's not
like a real romp, Christelle, so apologies for me going at pace, but I knew I had many slides to cover.
No, I think that was great. And I really liked the tool and the forms, and I'm curious to see what some of the questions are about. Someone writes, scripting can be quite helpful. Often guided discovery seems to lead to people managing their pain better once they've left their consultation. How do we encourage them to go off script as part of their exploration and encourage them beyond the Navigator tool to their own choices and own words?
Yeah, well, there is a wee section which invites you to include your own concerns, and you know, we appreciate that we kind of put together a list of probably the most common ones. But I think this would be a good starting point for a wider discussion about patients' lives. Bringing in all of those other aspects, I guess, gives permission to bring in other things as well that aren't necessarily as part of this tool, to bring in things like spirituality. For example, that's kind of one of the thoughts I had after listening into some of the talks yesterday.
Mm-hmm. And that leads me to the next question. Someone is asking if Scotland is integrating mindfulness programs for their patients. There's not enough of them available in Canada, but this person had heard that the NHS was embracing them. So I was wondering.
The NHS is embracing them. It's a difficult thing. I guess it probably relates to what Marianne was talking about earlier. In primary care, it's probably easier for people to recommend them because the link workers in practices will be aware of the availability of all these local resources. They are a bit piecemeal. It is something that's being offered in some specialist settings, and I have a consultant anaesthetist colleague who has a passionate interest in mindfulness and is fully trained in mindfulness meditation himself, and has introduced with another consultant clinical psychologist colleague mindfulness groups in the pain service in Glasgow. Unfortunately, I think a lot of the managers see this as expensive and indulgent for secondary care, highly paid secondary care healthcare professionals to be spending their time doing. But I think that's very short-sighted. And very recently, I attended a presentation by my colleagues at the North British Pain Association meeting where he discussed the benefits. They've been doing some research, so I think you can demonstrate that it is very helpful.
Yeah. Another observation is that we're often trying to change the patient's perspectives or approaches when perhaps the real issue and a theme we've seen this weekend is that the healthcare providers are the problem. What are your thoughts around embedding this type of program into university admissions, teaching, and mandatory continuing education sessions for licensed healthcare providers?
I think this came up yesterday in one of the sessions I sat in. Yeah, I think it's something that's bound to be happening anyway, organically. The self-management and the limits of conventional medicine are going to be discussed more in undergraduate programs. But I think one of the beauties of the Navigator tool, it doesn't rely on the healthcare professional having an interest in themselves going out and seeking training. The pain concerns form can be downloaded by any patient and completed and brought into a consultation. And that it puts them in the driving seat rather than relying on the kind of interest and openness of the specific healthcare professional to actually go down that route. And I think that's one of the dangers, isn't it? Is to say, well, we all have to be trained. And I think if we can get patients to push from their side as well, I think that's going to be helpful in the long term.
I agree, and I think some people just need, whether it's healthcare providers or patients, they just need a place to start, right? Yeah. So tick some boxes, and then we know how to, steer the conversation towards or where to start, right?
Yeah.
So I'm hoping that this tool is widely available to all of us. Is it?
Well, as I say, the downloadable PDFs from the charity's website, which is painconcern.org.uk, and there, as I said, there's lots of information on how to use it there with various videos. The kind of glossy brochure thing, I think the charity, well, it's got limited funds, so it's only produced so many. But I think I'm guessing that if you made a request for some to be sent out to you, they'd be happy to send them to you. And the charity they're not precious about this at all. They'd be, their aim is to improve the treatment of people with chronic pain. They're not trying to earn money from this. So, they're quite happy for you to reproduce any of these resources for your own use.
Okay. Yeah, so I just wanted to ask as well. Is there any guidance you want to give us before we start using it, or any rules or limitations that we should be aware of?
I would think that anybody who's attending this conference is going to be somebody who's interested in pain and has a kind of good grasp of self-management anyway. But I would urge you to watch the videos, and I think they're quite instructive and informative as well. And there are reports as well that are downloadable from the Pain Concern website to give you a bit more background information.
Mm-hmm.
But I don't think it's something that can really cause harm. So, you know, I'd encourage people to just experiment with it as well, and just give it to a few patients to see what they make of it.
Mm-hmm. I certainly know a lot of these kinds of tools are being used in the cancer clinics, and you know, you get a sheet to fill out when you show up at the clinic, and there's all kinds of concerns or issues that you can flag, and then then the healthcare providers know how to steer conversations and give you resources to get your needs met. So I think the model works quite well.
Yeah, that doesn't surprise me. It's kind of oncology has always been at the forefront of kind of holistic medicine. Yeah.
Well, and I think, you know, patients don't always know what to bring up. And I think that having a list of things to choose from, oh yeah, that's right. You know, I think it would trigger them to think about things. And
I think also there's that thing that I mentioned in the talk, which is that I think most patients and most healthcare professionals can see that, you know, people's problems with low mood or people's problems with being able to work has been as a result of their pain. And therefore, logically, you think, well, the only way that I can fix those problems is to get help with my pain and have that reduced. But if you can't reduce pain, then that's a problem. And people get stuck in that cycle of prescriptions of medication that's increasingly less likely to be helpful.
Mm-hmm.
Instead,
and the belief that they only, that medications are the only thing that will help them.
Yeah, and you can tackle those problems on their own without necessarily having to reduce pain beforehand.
Mm-hmm. Mm-hmm. Yeah, someone writes, I might edit it just a little bit. The patients are often desperate and lack inhibition when they communicate. Okay, so I think we sort of talked about that, and having the tool does give them you know, a fabulous way to articulate some of those concerns and things. Someone was wondering if you have any anecdotal stories or evidence to support this working.
There's lots of those anecdotal cases in the videos on the website. But yeah, I kind of mentioned a few of them that people were saying, the healthcare professionals were saying their patients were kind of exploring all kinds of different options now instead of just relying on prescriptions. But then there's many more examples in the videos where patients and healthcare professionals are interviewed on camera, and they're professionally produced videos. We're lucky to work with a retired BBC radio producer who himself is a chronic pain sufferer. So.
Oh, that's helpful.
They're quite polished. I urge you to.
Sure.
They're entertaining as well. Yeah.
Yeah, no, I think this is really exciting, and I can hardly wait to go check out the website and use some of the tools. And I really thank you and your team for all of the work that went into making them and making them available. So thank you for presenting this morning.
Yeah. Well, thank you for the invite.